Can somebody say something real quick, please?
Hello.
Marty, can you hear us?
Yeah.
And we can hear him. Good.
Yeah.
So far, so good. You'll start whenever you are ready. What happened is, first half hour, we're presenting 3 cases of various types, and then discussion, and then I'll present 10 minutes what you wanted, that why the STEMI numbers are down.
Okay.
Good.
Good morning, everyone. Everyone heard Dr. Sharma's preview of this morning. It's fairly nice Tuesday, May 5th. Tomorrow morning at 8 o'clock, the conference is sort of a continued panel discussion. People of various specialties talking about their perspective on this COVID crisis, and are we seeing any improvement, the mechanisms, pathophysiology. On Thursday, Dr. Larakis is leading a conference on imaging during COVID, some of the issues and some of the interesting aspects. And on Friday at 8 a.m., Dr. Pinney and Dr. Lala are going to present cases on heart failure and transplantation, and the challenges the time of COVID present for their unique patient population. So this is sort of part 2. Last week, Dr. Sharma and Kinney gave us a really wonderful talk about intervention in structural heart disease, and this is part 2. Dr. Sharma and Dr. Kinney, please. Thank you.
All right, Tarun, you introduce yourself and start.
Hi, good morning, everybody. My name is Tarun. I'm one of the interventional fellow. I've been assigned the job to present in front of you 3 cases during.
But can everybody hear it well?
Yes.
Oh, good. All right.
That's good.
We got upgraded audio visual.
Thanks to Andrew.
Yeah.
So I'll be presenting 3 cases, the urgent cardiac cases during COVID-19. So without wasting any time, let's move to the first case. The first case is 34-year-old male with no past medical history. He presented to the emergency department with 1-day history of non-radiating, sharp chest pain, which was worse with inspiration. In terms of social history, non-smoker, no alcohol use. He was on no home medications. On examination, he was afebrile. He was hypertensive with a systolic of 230 and a diastolic of 145. Heart rate, he was tachycardic at 112, and he was satting at 97% on room air. On other physical exam, pertinent physical exam, he also had mild bilateral crackles on pulmonary exam, but otherwise unremarkable rest of the physical exam. Here was the EKG. And if you can see, he's in sinus tachycardia. There is signs for LVH. There's signs for left atrial enlargement. This EKG was read as acute MI on presentation. It's some people can say maybe it is, maybe it is not. But if you take a look at the inferior leads, there is slight hint of ST elevation and some ST depressions in 1 and AVL, but it's still very non-specific. So for the most part, what do you guys think of this EKG? Anybody wants to? Anybody wants to take
inferior leads. Whether that represents epicardial disease is another question. Also, I would offer that a normal individual doesn't mount that blood pressure.
That's a good point.
It looks more of an LVH pattern, may plus minus hyperacuity. But that is typical. What did the EKG read? That's what our emergency room do.
It was read as LVH. It was read as acute MI.
Yeah, that's why they call. They based on the
Andrew?
Funny enough, the second EKG, which was done after 5 minutes, was read almost as similar as the first EKG, but without acute MI. This was the chest X-ray on presentation. If you can see, it was read as by the radiologist multiple bilateral hazy and reticular pulmonary opacities, felt most likely to correspond to combination of epilepsis and mild pulmonary edema.
Looks like now everybody gets a chest X-ray before EKG.
The ER staged the STEMI pager during this time. At that time, they had also done a point of care ultrasound. which showed EF was reduced about 35 to 40%, and there was diffuse global hyperkinesis. The decision at that time between the, after discussion with the interventional attending and the ER attending, was made to treat the blood pressure first with nitroglycerin drip, get more control on the blood pressure, and obtain further lab data and continue to monitor his symptoms. Any other differentials that come to your mind when you see the presentation so far?
I mean, it still could be MI. I mean, although it's a modified way, but LVH, patient presenting, could still be MI.
No.
Presumably, he has no other reason for LVH. Maybe if he has no past medical history, it may mean he's never seen a doctor. And so his blood pressure has been asymptomatic, unless they saw something else on the echo. You're stuck with those inferior leads that have ST elevation, not a lot, and it looks like it may be Q waves in 3 and AVF.
Yeah.
But it doesn't guarantee an infarct, certainly not from epicardial disease.
Very good.
Correct. And maybe PE may also be a differential, even though because the patient did come with acute onset shortness of breath, worse with inspiration, patient is tachycardic on presentation with sinus tachycardia, and those are some signs that can also lead towards PE as a differential or emergency causing acute pulmonary edema. Again, maybe he has not seen a doctor, uncontrolled blood pressure.
Let's not keep aortic dissection off the list unless you're sure it's not there.
Absolutely. That's a very good differential too. In the labs came back after some time, and the Pertinent Labs have been highlighted by the arrows. The white count was slightly up, 13.3. The D-dimer was normal, was within the normal range. So that takes care of, for the most part, one of the differential. Cardiac chemistry-wise, his BNP was elevated at 507. His cardiac markers, troponin was elevated as 2.38, and the CKMB was 16.4. These are the first markers.
There was no fever.
No fever. He was afebrile on present.
And after the echo, he became pain-free or still in coma?
So the patient was started on nitroglycerin drip. He was on 40 to 50 mics of nitro drip. His blood pressure did improve to 170 over 104 from a presentation of 230 over 125. However, despite all this, the patient continued to have chest pain, even though it was slightly improved in the presentation. There was continued discussion between the interventional attending and us and the ER physicians. Given the elevated cardiac markers, the initial cardiac markers and the ongoing chest pain, decision was made to proceed with coronary angiography while waiting for COVID results.
I think we can pause here because this is what one of the quality issue has been raised by some members in the hospital, that should it have been a STEMI process in this particular case, based on what has been presented here. So hypertensive emergency, pulmonary edema, and that EKG which we saw should have been a rapidly 90-minute target goal of STEMI process. So we need opinion on that.
Doesn't seem so. This seems predominantly hypertension and LVH, the dominant one.
The fact that there is no segmental wall abnormalities, no hyperacute contractility on the non-involved segments suggests that this is not an ACS, but certainly the EKG and the chest discomfort with heart failure makes it complex.
Yeah, no, but I mean, it still could be ACS and non-STEMI type situation with hypertensive emergency, but not a STEMI. So, right, STEMI is one of the issue here, and particularly this is what happening with the COVID era. There are delays, and that has been perceived by every society, and they actually have made that point because of these cases are in the past. 3 months ago, this patient comes in, you control the blood pressure, take it to the cath lab right away. There's no question there. Because that, you know, you make the diagnosis. But
I mean,
with continued chest pain and increasing troponin, yes.
No, I understand, but nobody will rush. Even in the non-COVID era, this will not be considered STEMI.
I agree with the new. I agree with the new. This is not the kind of situation that you would want to run to the lab. There's too much complicated stuff here.
I mean, as this is
Well, I think, Valentin, I think this patient correctly, this is a diffuse myocardial damage on a patient who has LVH. And I think the question is, what is the kind of injury? I think it's diffuse.
People turn off their phone if they're not speaking. Please turn your phones to mute.
Somebody joined the meeting and their top speaker is on.
Looks like it's better.
Okay.
All right.
This needs training.
So there is consensus that there is not an acute STEMI here.
Or possible. I mean, as a person,
Please fasten driver seatbelt.
ongoing chest pain, it wasn't the enzymes. The EKG obviously is bothersome, but the totality of the data to me suggested the.
Very good.
Right. Here's the coronary angiography.
Is that what he agreed, Dr. Stone?
Yeah, Dr. Fuster mentioned this point. Dr. Fuster, are you there?
No, what I said is that the whole case to me is a patient with hypertrophy, underlying perhaps hypertension, likely, and has a diffuse injury of the myocardium, and the injury can be of any kind. And you know, I cannot go much further, but I am not in favor of the diagnosis of segmental myocardial infarction.
Yeah.
So good. That's what
All right.
we talk. Good.
All right, to our surprise, this was the angiography. So this is the native. It's a left dominant system. And just to highlight, I know this will this easily takes anybody's attention is this mid-LAD lesion, but there's something else also going on in this coronary angiogram. If you pay attention towards the left circumflex and the LPDA,
It's subtotal, there is dye staining,
That,
thrombus.
that's probably culprit vessel. Okay, keep going.
But he has, underlying the CVD, that's why diffuse.
and just to show the post-intervention, so we ended up intervening on the LPDA and the mid-LAD, which was the non-culprit lesion, given the fact that he was not in shock.
Everybody agrees with the plan, and then subsequently patient did okay, managed.
This is the clinical course follow-up for in terms of the. He had a transthoracic echo the following day. His EF was 40% with diffuse hyperkinesis. In terms of biomarker trend, he went from TRO, which was initial of 2.38 and peaked at 36, with CKMB peaking at 9.1, and then it downtrended. His medications were further optimized and discharged home a day later after an uneventful course with follow-up. Sorry,
COVID.
He was COVID negative.
It is, however, what Dr. Fuster said. He has diffuse dysfunction, and by the way, he's got epicardial disease too. I guess we'll talk about that.
Okay. No, but the question is, the management point of view, will everybody agree that patient was managed appropriately?
Yes.
The only question that is the timing between admission and CAT. That's the only question. This is a STEMI that has to be lower than 90 minutes or not. The answer is no.
So the patient did not meet criteria for STEMI.
Okay.
Okay.
Very, very appropriate.
Good.
All right.
Go to the second case.
With that information, let's move to the second case, which is also pretty interesting. Here is a 48-year-old gentleman. Again, no past medical history. This patient came to the ER with a weak history of fevers, cough, shortness of breath, and diffuse chest pain throughout the precordium, which was worse with coughing and deep breath. Non-smoker, no alcohol use, and no home medications. In terms of vitals, he was pretty stable. He was afebrile, blood pressure 124/81, heart rate of 9, and he was breathing at 96% on room air. Rest of the physical exam was unremarkable. Here is the first initial EKG. Anybody wants to take a hit at it?
If you describe yours and then you hear from others. ST elevation of all your inferior and lateral leads, some
ST depression.
and ST depressions.
Right bundle branch.
Let's ask Dr. Stern. Our EKG guru, Dr. Stern.
As I said before, who died and left me in charge. So he's got, in addition to the right bundle, which may be incomplete, I'm not sure quite how wide, his ARD progression is pretty poor as well. I'm not sure what to do with that in a young man who's otherwise okay.
Well, there's a question of posterior involvement if you look at the V1 and V2.
Yes.
Yeah, but
incomplete
George,
right
you
bundle.
want to make this as George, you want to make this as infra-posterolateral with QL equivalents? I'm
could
not
be.
sure we
Yes.
can tell that, but we'll see.
Dr. Friedman saying something? Yeah.
Yeah, Sandy.
Can you hear me?
Yes.
Oh, yes, nice, beautiful.
Oh, wow. This technology is overwhelming. When you find the left axis and the ST depressions in the precordial lead, it goes with multivessel disease.
Okay.
Okay. So as you all said, it's diffuse ST elevation with a hint of ST depression in V1 and V2. There is incomplete right bundle branch block. This pattern may or may not be able to localize any culprit artery, or may be also seen in diffuse process like viral myocarditis.
Another question, yeah. Good. This one.
Next is the chest X-ray. If you take a look at the X-ray, this was described as moderate bilateral patchy and hazy pulmonary opacities in a lower to mid chest distribution. May represent an atypical viral pneumonia in appropriate clinical setting. Before I move to the next slide, I just want to hear what the audience would say in terms of ERCs this EKG and pages the STEMI pager. What would everybody do in this audience here?
And here it looks like my presentation. This is a patient very likely will have COVID positive, although you don't have it yet, results. But COVID pneumonia presenting with MI. Right? I mean, that will suffice to say, and of course, we need to hear the other opinion.
X-ray does not fit into COVID pneumonia,
it does.
but the entire history,
No,
because
why?
it's COVID.
No, but X-ray does. Yeah, that's the ground glass, peripheral and ground glass. Yeah, no, it fit. That's what they're saying. Viral pneumonia, typical viral pneumonia is
Right
COVID.
middle lobe. Just show the right middle lobe.
Okay. Any other opinion from this point? Whether should this patient go to the cath lab directly, or we want to wait? I think that's the important question at this point. Well, the discussion going on with the ER attending, the interventional attending, and fellow.
If they do an echo.
Mute the guys.
Somebody
I would do an echo first here.
Echo.
Okay.
No.
Okay.
You did echo?
Echo was not done on this one.
At that time.
Not of the point of care echo.
Not a point of care. Yeah, not POC. Was done later, but not at 1 a.m. in the night.
Anybody? Anything else? Anybody wants to?
Okay, what? Take the patient to the lab?
So ED activated the STEMI pager. Decision made not to proceed with coronary angiography, given high likelihood of presentation being myocarditis. From the symptoms, fever, cough, shortness of breath, chest pain throughout the precordium, atypical chest pain, worse with inspiration, worse with cough. EKG may or may not be hinting towards localizing a STEMI kind of picture versus a high likelihood of myocarditis. Rule out COVID was the next assessment and recommendation. Following day, some labs came back in the meantime, highlighted by the arrows. If you see on the left side, the white count is normal, but in some of the inflammatory markers are elevated. The D dimer, the first one was 7.2, fibrinogen was 593, serum ferritin was 600. If you just pay attention to the 414 labs, the first troponin was 0.63, and this was the initial information. Next day, the COVID also came back positive. His cardiac enzymes continued to peak and actually ended up peaking at 26 of troponin with a peak CTMB of 103. Echo was done the following day. He was admitted to the COVID unit. Echo was done. EF was 46%. It was described on Definity. The patient did get Definity for better delineation of the borders. It was described as mild moderate hypercontractility of basal inferior and infralateral walls. His chest pain, though, had resolved. He was started on heparin drip. General cardiology was on board as well. For COVID purposes, he was treated with Plaquenil and azithromycin, while also receiving heparin drip for 48 hours. He had an uneventful course. He remained hemodynamically stable throughout the next 48 hours and discharged home 2 days later without any complications with a cardiology follow-up and to further determine the ischemic evaluation on follow-up.
Now let's talk about very important point. 2, we'll come back from the STEMI activation. We want opinion. Second is what we know now of the disease process, even that during that time. Should this patient be on antithrombotic? Maybe expert in our audience can comment on it. Antithrombotic with a high D dimer. And
there's no question. There's no question. Has to be. He came in after all for possible MI as an indication for a heparin right away, or regardless of what we did or not to the cath lab.
No, I'm discharged. No, acutely, yes. Question is now outpatient for 2 weeks, knowing that patient is on DAPT already for a MI purpose. So should it be on added antithrombotic? And if you put it, then you take out the aspirin. That's the question.
I think so. That's what we follow in the medically treated COVID patients, that if they require full dose anticoagulation in the hospital, they go out on some anticoagulation for 2 weeks. So I would say I'm in favor.
Yeah, but I'd like to comment though. I don't think aspirin is sufficient here, because you don't know what is going on. This is a COVID positive patient. We have a paper today in JACC, tomorrow, which all patients COVID positive should be on antithrombotics at discharge. And the policy has been moving into not only aspirin, because aspirin is not sufficient, but it's a clotting system in general. So either subcutaneous heparin or apixaban or rivaroxaban. If the patient has low renal function, then you use apixaban. If it has normal renal function, you can use rivaroxaban. But the question is not to protect just the coronary arteries. You have to protect the whole system. And it's for 2 weeks is the advice.
Right. So therefore, this patient should have gone home on clopidogrel and apixaban.
Even he was on aspirin and Plavix. He was sent home on aspirin.
No, if you are not attacking the intravascular clotting by doing that. What you are really addressing is the coronary arteries, and we don't know if it is coronary artery disease or not. And the new data on apixaban and rivaroxaban is that they are also favorable for the coronary arteries.
Yep.
But aspirin is not favorable for the full intravascular clotting that these patients have.
Agree.
So, but why did we not discharge this patient on? I know this is a very evolving, this was a little early part of last month. Maybe we are still formalizing the anticoagulation protocol.
We never had anticoagulation protocol.
Exactly. This was a must have been an early case.
Oh, tell me the date. What date this patient was done?
April 14th, actually.
April 14th, yeah.
April 14? Okay. So April 13, the guideline came out.
So this was just that early.
1 day before.
Within 24 hours.
Yeah.
No, but the point is that's okay. This is all purpose of presenting here is to learn, and going forward that this is the kind of case, then even have MI. So 2 questions here now. We need to hear. Should this patient gone to the cath lab urgently?
No.
Definitely not.
Okay. But you are the cath lab guy. We need to hear from non-cath lab guy, because remember, this is one of the quality point has been raised by the hospital administration. So I want to hear from the non-cath lab team, should this patient go to the cath lab at that time when patient was presented? And I would say that after patient presented, you on medical therapy, patient did not break through. Waiting is completely fine. Question is, at time 0 when patient presented, clearly looked like it is a florid COVID pneumonia, along with MI, whether it's a myocarditis, it's myocardial injury, or it's a clear-cut type 1 MI, which could be anything in this case. And particularly regional wall motion later on actually points to that this patient has a CAD MI, because there is a regional wall motion abnormality. It was not just a global diffuse. So therefore, the question remains that at time of presentation, should this case be taken to the cath lab right away? And we need to hear from the non-interventionalist some opinion.
Well, Valentin, I have to leave, but I can tell you this maybe will be not.
Okay.
Why? Two reasons. One is a COVID positive patient, and you know how the literature is about doing these patients interventionally. And the second, this is a diffuse disease. I don't know if it is coronary disease, as I think Sandy Friedman mentioned, or whether this is a diffuse myocarditis or pericarditis or diffuse injury. So I would not catheterize this patient at this time.
Good. Very good. Let's go to case number 3.
All right. Moving forward with case number 3. Another young patient, 33-year-old male. He came to the ER with sudden onset severe pressure-like chest pain for the last 3 hours, associated with nausea and some shortness of breath. Former smoker, no home medications, no other past medical history. On examination, he was afebrile, normotensive, normal heart rate, starting at 97% on room air. Otherwise, rest of the physical exam was as well unremarkable. Initial EKG, again, if somebody wants to describe this one, please.
Dr. Stern.
Why there are no cardiology fellows there?
They're there.
But even if
Someone else can speak.
Yeah. But
Chris
guys,
Pummel,
give the
I think
opinion and then we hear from Dr. Stern, localizing which vessel and where.
Chris Pummel, I think I saw him.
Yeah, I'm here, Dr. Kinney.
Yes, let's go.
So, it looks like there's some inferior ST elevations with some cervical depressions and one in AVM.
There's more than that.
Yeah.
Okay. So the ST elevations go out to the lateral leads as well, and the R wave is awfully generous in lead V2 to go with the inferior Q wave in lead 3. If I were a betting man, because the vector points a little more to lead 3 than lead 2, you're talking about right versus circ. That's a different matter.
So from your point of view, it's the right coronary, right?
No, he said right branch.
Right, 3 greater than 2.
Yeah.
Well, the
AVL ST depression.
When 3 is greater than 2.
Large RC.
Yeah. I wouldn't be shocked at all if this were circ, but we'll see.
Okay, keep going.
All right. So the next step, again, red dash 30 MI. ER, call, pager. What should be the next step if somebody wants to kindly describe?
Positive or
No, we don't know.
No, just presented.
Symptoms.
3 hour history of
fever,
So nothing. By history,
33 years old.
Yeah.
Oh my God.
Unlikely COVID. Yeah. Keep going. So question is what to do.
This
How do we
patient,
treat?
take it to the cath lab.
At what time of the day?
This was 3:41 a.m.
How come they only come in the night?
So usual.
No.
Yeah. Any other opinion? Anybody else? What will you do?
In the pre-COVID era, this guy goes straight to the lab, does he not?
Right. Yes.
And now,
Even the question is now, what you do now?
I think this case, even now, will go to the lab.
In the absence of other systemic symptoms or suggestions, sounds like the lab's the right place.
Yep.
And it's not just a very small inferior MI.
It's a large amount.
Okay. George was saying something.
Well, one of the old situations while debating, sometimes we do a repeat EKG and see how that may go.
Now, very good. Now, no, that's a great point. Now, what about Roxana? Roxana is on the line or no?
There's no guidelines. So
Okay, go. Next. Repeat
guidelines
EKG.
only.
All right.
Yeah.
So ER activates. By the way, sorry, chest X-ray. Mild bilateral patchy hazy.
X-ray first, EKG after.
Yeah.
Pulmonary opacities and baseline distribution may represent atypical pneumonia.
Okay. Good.
ED activates STEMI pager. No emergent cath lab activation at that time. The recommendation for COVID, high suspicion for myocarditis. He was loaded with heparin and aspirin
Plavix.
and Brilinta.
Brilliant. Sorry. Yeah. Brilliant.
He also received POCUS and ER. It was per ER documentation. It was normal EF with low wall motion abnormality. Chest pain has hour 1.5.
Okay, let's go back. This POCUS was done by ED,
Yes.
not by cardiology.
No.
Yeah, but so how can we say no WMA?
No, that's okay. Why not?
No, they're not trained.
No, point of care. No, point of care echo. They're teaching the
They
medical
use,
students.
they do,
Medical students are having the
100%.
echo nowadays.
They're using the same ultrasound to check maybe fetus is
Yeah.
there or the heart is moving.
Echo is focus is the focus. Focus is part of the medical students now.
However,
We are attending medical students.
Right. I would caution that there's
Keep going.
nothing.
Next, in
This
the meantime, there's a second EKG. This is hour and a half later from around 5 to 10 a.m. This is a repeat EKG. Somebody wants to compare from the first one?
Actually, let's put this way. George was not on call, but he predicted correctly. Do the second EKG after little therapy.
No wonder they are asking.
Yeah,
for
now-
fluid.
now-
Yes, and
Not this one,
if the second ECG looked ugly, we would have missed the 90-minute window. More important than the window is we would have missed myocardium that could have been saved.
Okay.
That's just the minority view.
No, that's absolutely correct. So continue paying.
Young
This
guy.
is, yeah, young guy. Yeah.
We're not talking 8 years.
Yeah.
Okay.
Hindsight is at least 20/20.
Okay, good.
Labs are coming back. His D-dimer was not here, but it was normal.
Normal.
His first troponin was negative. These are two basically at the same time, so ignore those. So first trope was negative, and CKMB was drawn later. Cath lab was not activated since he was chest pain free. Second EKG.
What is that to activate? Now you guys have to follow. They're not going to keep activating now.
No, she's saying initially.
Last night.
Oh.
The following day, the OLG was consulted. He was being tested for COVID. His troponin started climbing up from negative to 5.8, and by 1:30 p.m. it was 20, and CKMB was 113. Still testing 3. Given the elevation in cardiac markers over the next 12-14 hours, decision was made at that time to proceed with coronary angiography. COVID was negative, resulted by that time. Here is the coronary angiography on the patient. You pay attention here.
For everybody, the distal RCA. And actually, same. Eric predicted RCA versus CERC, RCA more.
And there's,
Yeah.
there's a stent there.
Yeah. And then stent was placed.
PCI after sending the distal
That's
RCA.
good.
Yeah.
Good work.
And then had a regular echo.
Other side, left, no?
Left side was
Normal.
That's why I didn't say it.
The CERC was normal.
Show it.
Yeah, should have shown it. But
Yeah.
CERC left system was completely normal. This was just a focal ruptured plaque. I mean, unbelievable. In this particular case, 33-year-old, and he had no risk factor. He had nothing else.
No, he's a former smoker.
Former.
I got it. He smoked
it's
over 10 years ago.
Yeah.
What was his occupation? Uber driver?
And I will say, I was a person on call, and this was, it's always tough to not take somebody, but there were a couple other things. I think Taran did a great job presenting. Actually, on the phone with the ER, I was asking questions of the patient, and I could hear the conversation with the patient in the background who was really pain-free almost at the time of the activation. I know the EKG was however many minutes afterwards, but certainly the patient was pain-free. Yeah.
Patient reperfused.
Near immediately, yeah, exactly. And of course, we don't put everything on the focus, but certainly looking at the pretest probability in this guy, of course I was wrong, but I had minimized his pretest probability for this in epicardial. And I don't know if my mind was biased in that, we're on this big WhatsApp group of interventionalists where there's been so many cases of regional ST elevations without epicardial disease. Certainly, he didn't have a COVID history, he didn't have COVID symptoms. And I agree that pre-COVID, we probably would have we would definitely have a lower threshold to take him. I might have done a CTA if my pretest probably was so low. But if the EKG didn't resolve or if he had chest pain, he would have went, regardless. But
yeah. So that's the point.
Yeah.
Well, the good news is, if he opens spontaneously, he's bought himself some time and bought us some time.
Yeah.
So this is not a tragedy. It's not bad. It's the natural course of sometimes what happens with ACS.
Yeah, and certainly there is TIMI 3 flow on the first angio, which is great. That said, all of the trials that showed benefit, this patient would be included, regardless of active chest pain at that moment, be chest pain within 12 hours, which he qualified and ST elevations as well. So even the resolution doesn't necessarily, but clinically and just kind of the art of medicine, the belief that he reperfused was high if this was epicardial disease.
And if patient would not have continued pain another half hour or 1 hour, and the ST elevation continued, then patient would have gone to the doctor immediately, pending the results of COVID.
Hey, Nitin?
Yeah.
I want to ask, quick question.
Sure.
I want to ask if the presumptive diagnosis in the ER or when you saw the patient was myocarditis, why, and he was COVID negative, why wouldn't do cardiac MRI the next day or?
Well, I don't know. I think that's some words that were written by the ER.
Yeah.
I mean, I actually didn't, conclusively think that, because he didn't have, like, the middle patient had like fever and chest pain and dyspnea, but between just prevalence or likelihood of COVID, even without symptoms, based on the chest X-ray read and just the lack of CAD risk factors, knowing that there's still a finite risk for him, and ultimately that's what it turned out to be. That would have to be the presumptive explanation for the EKG changes. Although I don't think we understand why are these patients having some of these regional EKGs, even those that have the coronary angios that are non-obstructive. So
the dramatic change of the EKG
Tells
is
you that.
against myocarditis.
exactly,
that's the
agreed.
Yeah.
But at that point, that wasn't the diagnosis, and certainly it was more likely to reperfused MI. But in this era, where at that point I thought there was no ongoing myonecrosis, for staff safety and just knowledge, knowing his COVID status seemed to be the right strategy,
So Nitin, what understanding that the pretest was low going into that, and you had a diagnosis of potential myocarditis, what was the reason why they were given ticagrelor? Was it because the ER just did it up front?
Yeah, but to be perfectly honest with you, well, that too, I mean, I wouldn't have been against it because I think the pretest for both was low. I mean, he has to have something, obviously, but it's not like he had a ton of COVID risk. And I actually don't know, but maybe someone on the line can say, like, these patients that do have COVID myocarditis, I know it's less likely, or at least the ones that have found to be, non-obstructive CAD. I imagine that the majority of them have some antecedent viral syndrome, because this guy didn't have that, which would obviously go more towards CAD, which it ultimately turned out to be. So.
Okay.
But,
For what it's worth, I also.
One second, somebody saying, yeah, what?
I was going to say, I would not be eager to send somebody to MRI when there was a significant likelihood of ACS until we had proved it wasn't. Not a good place to get sick.
I did hope to get a CTA actually, but I don't know the logistics of that, especially.
Still don't require COVID positivity at that time.
No, this patient had 3-hour chest pain. You should have seen an inferior wall motion abnormality when he presented to the ED.
No, but he didn't even have it on our EKG on that thing.
No, I'm just trying to say the focus done by ED is wrong.
No.
Going back to the same point. And just to tell you, even in
So
the
show
COVID
minus
era,
Yeah. Actually,
what is it saying?
Dr. Guinea, I have talked to the people in the ER regarding POCUS, and apparently the people who do POCUS and report POCUS, they are attendings, they are certified doctors to do this POCUS, like a cardiac POCUS or lung POCUS or different things that they see, so they are certified. And because I'm doing a project on this and I'm reviewing the images, but I just want to make the point that these guys are certified to do ultrasound of the heart, of the lungs, so they make a report.
Very reassuring, good.
Sometimes these are not easy calls, but I stand, it's STEM, it's fine.
Can I just make a comment about cardiac MRI for a moment?
Yep.
But even on these patients that were doing, hi, it's Gina. Even in these patients that were doing MRI acutely in a convalescent stage, 3 to 4 days prior to discharge and so forth, we haven't really seen anything yet. 2 patients that we did yesterday that was an acute cardiogenic shock, the 20-year-olds that came in with Dr. Pinney, we're just seeing enhancement of the papillary muscles. We're not seeing diffuse myocardial involvement. And so I'm not sure if we're getting it at the wrong stage. Are we getting it too late or even too early? And that's why we're thinking maybe these patients.
Yeah, but in the literature, I think the lot of MI or presentation of cardiac presentation of COVID are there. Myocarditis is on the very low. Their myocardial injury, STEMI, even normal coronaries and so, but myocarditis is very, very low. One of the review articles said it's a rare, some autopsy finding very rare. So myocarditis of the COVID is on a very low diagnosis, like 8.
Completely agree. Completely agree. That's what I was saying when
By the
there weren't too many referrals for cardiac MRI. But in the beginning, when they were, we weren't seeing much myocardial involvement.
Okay. What else?
Just that any
Yeah, good. Just want to show one
just
slide.
want to show.
Okay, going back to the question, you asked the question in the first 2 cases. In this case, was it the right thing not to bring the patient to the lab?
Because the STs change. So patient reperfused.
I would have brought the patient to the lab when the first calculation.
I mean,
Because it's
it
a
was
young guy,
obviously a judgment call.
no exposure to COVID, chest pain for 3 hours, EKG changes. There's no other patient that you could have saved myocardium than this patient.
No, but he got chest pain free.
Compared to the first 2, I agreed. You know, you could have held it.
what is the timing between the first and the second?
EKGs was long.
341 and 520.
His EKG got better because he reperfused from the heparin.
Yep, heparin and ticagrelor or everything, yes.
No, other thing also
might
is
open
for
it
us,
because we
this
can't-
patient, once it's referred to interventional cardiology, it should not go back to cardiology consult. It should be under the.
But
Definitely.
we need
Very
consensus.
important.
You cannot now have a third layer to tell you, take the patient to the cath lab.
You take 1 minute, finish yours, and then we go to the next point.
Just want to discuss this case series that was published earlier in April by Dr. Shipal. ST segment elevation in patient with COVID-19 was a case series of 18 patients, and they described the non-obstructive patients with COVID-19 but non-obstructive disease on coronary angiography, or had normal wall motion on echo. If the coronary angiography was not done, they were called non-coronary myocardial injury. Going to the table, so if you take a look at the MI and the non-coronary myocardial injury, there were 8 patients who were found to have MI, and 10 were determined to be non-coronary myocardial injury. 50% of patients with the non-coronary had risk factors like hyperlipidemia and history of previous CAD, compared to 29% and 0 patients who actually ended up having MI.
What is non-myocardial, non-coronary myocardial
Not
injury? If it's not
epicardial.
myocardial,
It was
no, if it's,
non-obstructive
It is
CAD.
I get
coronary,
that.
but not
I'm-
epicardial.
Just use the word myocardial injury. That's it. That's the word.
but it's
Don't
not
worry the
myocardial.
non-coronary. We call it myocardial injury.
Minoka.
I know
In
that,
terms
but
of
that's not myocarditis.
In terms of symptomology, patients did come with chest pain and fever and cough, shortness of breath, respiratory distress as constitutional symptoms. In terms of that, in 60 to 75% patients with MI, with myocardial injury, versus 10 and 70 and 90% patients in the non-coronary myocardial injury. In terms of EKG, patients who were determined to have MI in the end were no diffuse ST elevation versus 40%, and 8 of them, 100%, 8 out of 8 had focal elevations compared to 60% of patients determined finally to have non-coronary myocardial injury. In terms of regional wall motion abnormality, 75% patients with MI did have regional wall motion abnormality. There were 6 patients in the myocardial injury out of the 8 patients who went for coronary angiography. 5 did undergo PCI. All of them did have obstructive coronary artery disease.
So, but 6 out of the 14 that had focal elevations did not have. So nearly half of those that had focal elevation did not have.
The peak troponin was 91 versus 13. And the D-dimer was also high in both the groups, 1900 versus 858. 4 of the patients, unfortunately, 50% patients died in the first group versus 90% on the second group. With that information, there are some EKGs from that presentation. If you take a look at it, these were all the 3 out of the 18 patients. I've just put their EKGs on. So if you take a look at this one, you can argue there's ST elevation in lead 2, lead 3, 1 AVL with some reciprocal changes in lead 3. In this one, you clearly see ST elevations in 1 AVL, B4, 5, 6. It's actually more diffuse, but there is some ST depression in lead 3. This one is another EKG, has PVCs, is tachycardic. There are ST elevations in the inferior leads. In general, if you have to determine, would you think that these patients would end up having true STEMI versus not?
30% got angio. That's a question.
And a half got angio. Half got angio.
Wow.
And then of the half that got angio, 2/3 got sulfur.
So funny enough, all three patients, their codes were negative, so they did not have any obstructive CAD with these presenting EKGs.
Okay, that's coming back. Okay, very good. Good presentation. You need to come here. Now we have the second part of the presentation. Oh, what happened now? So, any other question now? Anu, you wanted to point about some recent paper? You wanted to say something?
No, that recent paper was ACE inhibitor.
Yeah, ACE inhibitor is no longer.
Actually, it's a positive predictive and statin. Just that is the New England Journal.
ACE and exactly. So let's just talk.
Female sex, ACE inhibitor, and receiving statin.
Predicted for what?
Lower COVID death.
COVID death compared to age, and of course the rest everybody knows.
And lung disease. So
no,
basically,
ACE inhibitor was questionable, right, all this time. But now this one article it's protective. Statin, ACE, female sex.
All the conclusion, they didn't say it is protective. They just said it does not harm. It does not harm. That's what we use. So both ACE and ARBs, both of them they tested. Both were equal. I mean, not there. ARBs was no, but I'm saying ACE was clearly protective. But since was the both group, it did not conclusion did not say ACE is protective. That's the key. They say it was not harmful. Now this is basically just very quickly has already been presented very nicely with ACSMI, type 1, type 2, STEMI with normal coronary, myocardial injury, and myocarditis. Actually, I don't know whether I just came out for what turns out to be the mortality of these MIs are very high. You saw that a small series. If you have even you with a classical MI was 50% mortality, myocardial injury was 90% in this 18 patient study. So very high. And of course, the rest of the presentation is there. So anyway, so we have made now, updated our algorithm after yesterday's QA meeting. We'll be sharing with everyone. And basically what we have revised, and this is goes with what is happening in the country. And that is that now we need to rethink that even these patients who are being tested for COVID, whether they are negative or possible versus those are positive and maybe probable, like the case number 2, which was presented. So those cases, so we need to be prepared. So initially there was some recommendation using thrombolytic. As you see here, we have removed thrombolytic completely if patient present at Mount Sinai Hospital. And this is the input for all our team yesterday from the cath lab and what has been presented in the literature. So basically goes down to if your classical MI presentation like case number 3, whether you are COVID there or not, you take this patient to the cath lab. If they are probable, those are the ones you do a focus. And if you had confirmed regional wall motion abnormality, it's okay to take them to the cath lab in a dedicated cath lab, and then those patients go for separate ICU bed or telemetry bed. This is the key. So these patients then should go to the dedicated COVID unit. And if there is a question, then you get into all this coronary CTA and full echocardiogram, and then decide whether you should take this patient to the cath lab or not. So this is where the whole issues are. That you can do a weight, serial testing, your troponin going up, that patient belongs to the cath lab. So if patient, nothing else is, the patient is not in the florid symptoms, and this is what we had done. If florid symptoms and comorbidities, which can be subjective, but patient, if we think is an 80-year-old has CVA in the past and has COVID positive and even have STEMI, I think that's okay to patient just comfort care and guideline directed medical therapy. Primary PCI of course remain. No thrombolytic at Mount Sinai. We have added based on the note from ACC recommendation that thrombolytic therapy from the transfer hospital, non-PCI, will be appropriate only if there is unusual delay. You think it's 2 to 3 hours, patient will not go because of no ambulance available, no doctors there to take care of the transfer of the patient. So many issues, but that if really delay is perceived, then those patients should get thrombolytic therapy. So this is the new updated, and this is what will be sent to everyone now shared. So second question is last time Marty asked, and I'll just do very briefly because we are working on this. That is the incidence of acute cardiovascular and STEMI in the COVID era. And is it true or it is a collateral benefit of our change behavior in practice. So clearly, what has shown that there is a 30 to 70% reduction in number of STEMI coming to the hospital globally. Now, this is a 9-center study. ER activation, as you can see here, used to be 25 per month, and that gone down to about 12. So clearly, the number of STEMI activation or 911 call in 9-center has significantly declined in last 2 to 3 months. At Sinai, this is the non-STEMI number of 2020 from January, February, March, April. Now, and then STEMI, last month we had 2. So these are all combined, transfer everything, not necessarily just coming here. So definitely STEMI number is going down. The second, this was part of our New York Times story, as you can see, particularly the numbers are going down here as well as globally. Dr. Fuster pointed out, I said about my hospital in Jaipur. And the question is that could it be there actually fewer medical emergencies now? Dr. Fuster speculated that perhaps people are healthier because they are eating better, exercise more, and under less stress. Now that so many are working from home. And of course, you have the cleaner sky, less pollution, and we'll come back to that point. Also another report from Cigna, acute coronary syndrome claims have significantly declined by 80%. And I have quotation there, reason the same. But key is that it's not only for STEMI, even acute coronary syndrome. Now we know electives have been stopped, but the acute coronary syndrome also hospitalization has decreased. Now, the other question comes, it's in the paradox. Paradox is because anytime you have pulmonary issues, the respiratory influenza, you have high incidence of STEMI. So if you can see here, this is a study from Canada published in NEJM 2 years ago, that influenza and incident ratio of hospital admission. First week, 6.3 times, 5.8, and even you have other viral illnesses, respiratory syncytial virus, other respiratory illness, there is a 3 times more. But COVID, which is primarily the disease of the lungs, respiratory, we are not seeing that STEMI has been seen. So therefore, the question is, what are the reasons? So we actually put down overall improve mental physical health, balanced diet, home cooked meal, decrease pollution, and of course, is it the less patients going to the emergency room, which is possible, but will not explain such a dramatic reduction because ERR, the 911 activation has already decreased. So clearly that some patient may be dying at home, nobody can decline, but I think it's not an explanation for it. So one of the things is pollution. Look at the clean, everything. This is just to give the example of the India, one of the gate, India gate we call, this is before in January and this is now, so clear. So and we know that pollution is directly related. There are a lot of papers on this issue. And one of the very good example was that in 2008, China Olympic. At that time, the country banned all the factories and the regular transport except the buses and so. At that time, the pollution went down by 70% and the cardiovascular mortality and STEMI decreased by 60%. So there is not only that pollution caused the MI by various regions, whether, causing active free radical activation and with the, release of various factors and so, but decreasing will result also in a better, lower STEMI and acute coronary syndrome. To me, since the effect is so dramatic, we saw within few weeks, the diet exercise is unlikely to explain that happened that quickly. So the studies are already presented that there is a low level of air pollution. Now this is the second point which we have done, the reduced chemical and gustatory triggers of disease, less visit to restaurant. You're not having that your fancy with the high fat food with the adulteration. So no less endothelial dysfunction. As you remember, there is a study early time that you have a large hamburger and there is a decreased endothelial mediated vasodilatation in the brachial artery and so. So all these things have created a problem, and better food is probably responsible. Now, only issue comes, this better food, if you don't do exercise, this is the second part. On long run, you'll have more coronary artery disease. And the second is the improved physical and mental relaxation. And of course, you don't do excessive exercise, better medical compliance. I think all of them are helping out. Now, is there a relationship? This is another paper from JAMA, that relationship of the healthy lifestyle with the BMI, smoking, leisure time, physical activity, and alcohol consumption. They took 4 factors, and they found that if there's an adequate threshold, if you meet these 4 requirements, BMI, smoking, leisure time, physical activity, alcohol consumption, and you can see the relationship is clear cut that you are maintaining your healthy lifestyle score. The lifespan increases. These are study from age 40 to 75. Very clear cut, direct correlation of a healthy lifestyle in the recent times. So it's nothing that is something old. It's a recent data to show that it does. The healthy lifestyle also improves the overall life. So key is all these factors probably are contributing to this. But most important point we want to say is that don't delay home. And this is part of the New York Times. The story was 2 of our patients were who presented late with MI. So don't stay home and don't have the death at home. That will be the whole counterproductive of this COVID-19 containment strategy. All right, Marty, this was the explanation which I told you that we'll do it today because it was a too short of time last time.
Well, that was excellent. Are there any questions? You know, the cases that you presented were young people who otherwise were asymptomatic. You want to make a comment about the age-related presentation of these patients?
But they happen to just present with the MI.
I think the ethnicity may have a difference, and nobody asked the occupation for these patients. I think they were all cab drivers.
No, one was the food delivery person.
Yeah,
But
same thing, whatever, delivery person.
But
Probably
exposure has
stressed
been
out.
there. Yeah.
The COVID time, they are stressed out. They have to deliver food to multiple people.
So message has to be that yes, there may be a decrease in MIs, but more importantly that that those who get into trouble get them, and this is what's going to happen. And I know that our volume also and everywhere, not us globally, the country-wise, the state-wise, here, the New York, the patients could wait this 4, 6, 8 weeks time, and now they started having symptoms. A matter of fact, I just admitted 2 patients yesterday with non-STEMI. These are CAD patients. One of them we just checked, MB is 68. The patient's on the table, we're going there now. So key is that I think whatever they could do with a medical therapy, they waited a little longer, but
yeah, good food.
But some
and now they're having MI.
But at the point
right.
is the message, what is in the public, or perception that you go to the hospital, you are going to get COVID. And that is where will be the toughest time for us to convince patients to come now that we have a COVID-free unit. There is a COVID-free labs, and then of course we are trying to make with the bad elevators which are written that those should be, like patient COVID-free, some kind which does not, I know there is a very controversial, but as long as it's a non-inflammatory point of view, that these are the dedicated, you can just say the elevator for cancer patient. You don't have to say COVID or so.
No, but I think the public is aware of the asymptomatic COVID positive patient. So like conceptually, there's some logic gap there. I think it's still a good idea to make them feel better, but a lot of at least well-read people will know that.
Don't go to the hospital.
Yeah.
But I think we still have to keep promoting. They have symptoms, they have to start coming. But I think what will happen now onwards is anxiety will play a important role as long as they don't keep giving stimulus check.
Irrespective of why they're coming or not coming, we still have to deal with the significant increase in crude mortality every place compared to seasonally adjusted. So why they're dying, I'm not quite sure. They're underdiagnosing. The other thing is fortunately or unfortunately, you folks in the cath lab have nicely presented a way to cut your revenue stream by making everybody healthy. But we don't have to worry, given human nature, people aren't going to stay healthy. Not a problem.
Yeah, that we know. Don't worry. I don't think eating at home will stay for long. They definitely start doing.
I agree.
Well, what's interesting though is that the alcohol consumption has gone up. Liquor stores are considered essential. Yeah. Why haven't we seen a steady stream of cardiovascular or acute coronary syndrome?
No, but I think the point is the alcohol with a heavy meal is the one.
Yeah.
That synergy. Alone alcohol is probably protected.
The red wine is fine. Continue drinking.
Right. No, Gina, the problem is it's dose related. They just haven't had enough yet to kill the virus.
Okay, guys.
And the second point is alcohol kills coronavirus. That was CNN news 2 months ago. I think with that statement, we end our today's presentation and thanks everyone to be participating.
Yes, so does Clorox.
And bleach. Even bleach. Somebody said drink bleach on the page.
It was a great conference. Thank you.
Thank you very much, Dr. Sharma, Dr. Kinney.